So hello everyone and welcome. We have a greatest pleasure today to present Dr. Sebastian Tume, who is assistant professor of pediatrics at Baylor College of Medicine, and he is equally clinical faculty member in the section of pediatric critical care medicine at Texas Children's Hospital in Houston. In addition, he is a medical director of Texas Children's Cardiac Critical Care Unit, which approximately 54 critical care beds and accommodating above 900 cardiac surgical cases and around 1,500 admissions per year. Furthermore, he has administrative duties, and his clinical interests include hemodynamics monitoring, management of acute heart failure, and pediatric mechanical circulatory support. Dr. Tume has published several book chapters on hemodynamic monitoring and mechanical support, as well as peer-reviewed publications on management of heart failure and pediatric mechanical support. So welcome to you, Sebastian, and over to you.
Good afternoon, everyone. I have to remember because it's morning here, but good afternoon, everyone. And thank you so much for inviting me to give this talk. And hopefully I can share some of our experience, provide you a little bit of information about the device and help you sort of entertain this mode of support if ever it comes around or you're interested or your institution is pursuing it. So I'm really happy and honored to be able to speak to you guys. I'm originally from Poland. I was born in Poland, so spent most of my medical education and childhood in Poland and now in Texas Children's. So thank you again. I'm just going to start by just stating some disclosures. I have no relevant financial relationships. I do function as a board member on Abumed Pediatric Advisory Board. I have to say that the devices discussed in these presentations are not FDA approved for children, and we will be presenting some unpublished institutional pediatric data in this presentation, so for everyone to be aware. I don't think we can start conversation about mechanical support without actually appreciating the burden of critical heart failure in children, and I think it's been really nicely delineated in 2019 by publication from one of my colleagues, Javier Lassa, who has actually really nicely utilized the Pediatric Cardiac Critical Care Consortium database out of the quite a few institutions in the United States that report into this or input data into this consortium. They have actually looked at the burden of critical heart failure in children in US population. And we now understand that around 5 to 10% of admissions in the United States are due to critical heart failure. Around 50 to 60% of these children require some form of invasive mechanical ventilation. And it was interesting and eye-opening that 10% sustained form of cardiac arrest, with approximately 35% of those requiring ECPR. 15% of these patients undergo some form of mechanical support, and mortality is described around 45%. And we know that around 15% of these patients that did not survive to admission. So quite a significant burden on certainly on our ICU, and quite difficult population to manage. A couple of years ago, Yagerlada and Dr. Lords have actually dug a little bit deeper into understanding a use of temporary mechanical support in our critical heart failure patients. And we have observed a significant increase in utilization of these devices certainly over the past 5 to 10 years. We have seen an increased use in CenturyMac and PediMac for a temporary VAT support. These publications do not include ECMO. We have seen a use of tandem heart, Rotoflow, and an Impella device as well. Dr. Lords has further sort of delineated the population that receives these temporary mechanical support, and we can see that patients are getting younger, smaller, and sicker. So we are learning more, and we are approaching more and more challenging populations with use of temporary mechanical support. We see that many of these patients, more 90%, were Intermax 1 and 2 categories, so still seeing quite a few sick children getting onto a temporary mechanical support. And however, the light at the end of the tunnel is that there are 71% of patients have positive outcome from this. So that is good to see. We can see that that primarily it's quite evenly distributed in regards to the strategy that's used. So bridge to transplant, candidacy, and recovery are the primary sort of choices for the use of these therapies. I think it's also important to understand sort of how do we manage or how do we approach a patient in critical heart failure and in cardiogenic shock. And I think it's most important to understand that the shock has to be identified early. It has to be identified before the compromise in organ perfusion, a compromise in coronary perfusion progresses to actual failure. So the whole idea around management of these kids with shock is to reverse the spiral of death and prevent myocardial injury, provide more myocardial recovery in these patients, and stabilize over circulation and organ function. I think it's important to also appreciate specifically the physiology of the critical heart failure and the strain that it places on the myocardium. And this is what sort of underlies the entire deployment of this mechanical support therapies, primarily to enable a myocardial recovery if we can, and if not, obviously a transition to some form of a transplant or primarily a transplant as an end therapy. I think the approach to a pharmacological therapies has to be sort of based on the understanding of myocardial energetics and myocardial loading. And we know that the pressure volume loop of the left ventricle represents the stroke volume. The area to the left of that pressure volume loop represents potential energy. So this is actually described as a pressure volume area, and that is equal to the myocardial oxygen demand. So the whole purpose of managing this critical heart failure and a myocardium that's under stress is actually reducing this pressure volume area, thus reducing myocardial oxygen demand. So we want to minimize myocardial loading conditions, and we want to optimize energetics, and then obviously evaluate response to our therapy. So we know in compensated heart failure, that pressure volume loop shifts to the right, creating higher pressure volume area, as well as increased myocardial oxygen demand. And then in the compensated shock, that pressure volume loop moves even farther to the right, further increasing myocardial oxygen demand. So the whole goal of mechanical circulatory therapies sort of, I think, circles around reducing this type of a stress on the myocardium, and at the same time, obviously optimizing end organ perfusion, coronary perfusion, and stabilizing circulation. So choosing how do we choose the right mechanical support strategy? We have to identify non-responders and consider, I think this is important, we have to consider mechanical support early. We have to shift from medical therapy to the mechanical support strategy, not as a last resort, but simply as a next step. So identify it early and deploy it early. I believe that that's going to result in a much better outcome in our patients. We have to define also an endpoint for mechanical support. Is it going to be a temporary? Is it going to be a durable? Is it going to be a bridge to decision or a bridge to transplantation? And at the end, which device do we use when all fails? There's plenty of support therapies available out there. And I think every institution carries their own sort of algorithm and approach to choice or decision on which therapy to deploy. I think in the setting of cardiogenic shock, the most common therapy that is deployed is the VA ECMO. It's primarily done, why? Because it's a rapid percutaneous deployment. It has a rapid percutaneous deployment capability. Many staff are trained. Most of the institutions possess this type of a therapy. It provides full biventricular and respiratory support, so enables us to stabilize the patient. Provides a basic support with various anatomical constraints, so patients with congenital heart disease, complex lesions. This tends to be straightforward, sort of a common, understood by intensivist mode of support. And then it buys us time until recovery without commitment to full sternotomy or ventriculotomy. However, ECMO comes at its expense. It has a high risk of adverse events such as stroke. And we know from multiple studies described by Rosano, Jagerlanda, and quite a few other studies that ECMO is not the best vehicle to achieve transplant in the patients. The patients who have had ECMO as the support therapy to the transplant have much worse outcomes after transplant than those that have been supported with temporary VATs. Also, you have to understand that ECMO does not always provide sufficient ventricular unloading. And this takes me back to the pressure volume loops that I have described. So it's important. The optimal mechanical support should provide that direct ventricular unloading, decrease wall tension of the myocardium, and thus decreasing myocardial oxygen demand. It should increase myocardial oxygen delivery, and then obviously endpoint would be a reduced inotrope dependence. So we know that peripheral VA ECMO, through cannulation of the atrium, right atrium, and the aorta, can actually increase an afterload on already sick myocardium, reduce ability of that myocardium to eject, increase end diastolic pressures, and thus cause increased myocardial oxygen demand. When we cannulate the heart through directly either left ventricle or left atrium into the aorta, so with temporary mechanical support strategies, we can actually generate much more favorable myocardial environment by shifting a pressure volume loop to the left, decreasing myocardial oxygen demand, wall tension, and directly decompressing the left ventricle. So this is what takes me to a discussion of the specific therapy that we've sort of entertained almost 7 years ago at Texas Children's. And the therapy fits in the short-term temporary VAD spectrum of our mechanical support. And many other institutions utilize Rotoflow, and we do as well for some of our smaller patients. Some institutions utilize CentriMag and PediMag for temporary support. There is obviously case reports and case series of tandem heart being used. And then Impella has recently commented to a picture in pediatric population as another therapy that's available for our older children and older patient population. So what is Impella? Impella is a percutaneous VAD. It's implanted across the aortic valve into the left ventricle. It's implanted through a large peripheral artery, so either femoral, subclavian, or axillary artery. The device comes available in various sizes and support levels, and ranging in various types of flow, anywhere from 2.5 liters all the way to almost 5.5 liters of flow. The device draws blood from the left ventricle directly across the catheter and then ejects the blood directly into the aorta, thus reducing volume and pressures in the left ventricle. There is a wide selection of Impella devices on the market, and the main differentiating features of these catheters include size, a specific output for the device, monitoring capabilities of the device, as well as insertion, location, and techniques, which are dependent on the size of the device. The Impella 2.5 is the smallest catheter that's available. That catheter contains a pigtail, which is located which would be located in the left ventricle. The catheter has a 12 French pump motor, so requires at least a 12 French sheath, and can be inserted peripherally through either femoral, axillary, or a brachial artery. Impella CP is the next in size of the left-sided Impella devices. It comes in a bigger size. It can generate up to 4.3 liters per minute of flow. And it comes in a bit bigger size of sheath with 14 French motor. And this device can also be inserted percutaneously, either through femoral, most commonly through a femoral artery approach. And then we have two, what I call the Porsches of the Impellas, which are the larger size of Impellas, Impella 5.0 and Impella 5.5. Those can generate up to 5 and 5.5 liters of flow, if not even at full boost settings. They can generate, the 5.5 can generate up to 6.2 liters of flow. So that should be sufficient for a full cardiac output in a big adult patient. The difference between the two devices is the presence of pigtail. The 5.5 is the newly designed device, which actually eliminated the pigtail. Those devices can only be inserted through a surgical chimney graft, either directly into axillary artery or into subclavian artery or into the femoral artery. The current Impella support options enables us to actually support the left ventricle and the right ventricle. I will not be going into the details of the Impella right-sided Impella RP support, as the device is a bit different and requires sort of a separate discussion here. but I'll be covering sort of the management and use of Impellas on the left side, which are Impella 2.5, CP 5.0, and the 5.5. In the United States, these devices are FDA approved through a variety of procedures, especially in the adults for high risk percutaneous interventions, cardiogenic shock management, and right heart failure for an Impella RP. The Impella 2.5 and CP are approved for less or equal to 4 days of management of cardiogenic shock, although we have used it outside of that indication. And the Impella 5.5 and 5.0 are approved to for use of 14 days or less for management of cardiogenic shock. And we have also, in many other centers, used it for longer than that approval. So where does the device find itself sort of in the management of various sources of cardiogenic shock? So adults primarily use a device for cath lab support of high-risk procedures. The device is, as I mentioned, approved for management of cardiogenic shock. It's finding its place in the ECMO support and left heart venting during a peripheral ECMO, VA ECMO support. It's used as a bridge to decision or transplant, and then circulatory support during high-risk surgical procedures. So adults have quite a few publications and quite significant experience with this device in a cath lab setting during especially high-risk percutaneous coronary interventions. The data in pediatrics is lacking. I don't think the device has found itself yet in that environment. Cardiogenic shock remains another indication for its use, and adults have sort of explored the benefits of the device quite extensively with multiple trials that I have highlighted here. The device has shown that it's a superior hemodynamic improvement when it compared to a balloon pump in patients with cardiogenic shock. It provides much higher cardiac output in these patients and is able to reduce end-diastolic pressures. Impella 5.0 has been studied in patients with cardiogenic shock and shown to have reduced inotropic score, lactate levels, and improved left ventricular ejection fraction. And in the IMPRESS trial of severe shock study, the Impella has been shown to has not been shown to have a survival benefit at 30 days. This is one of the arguments of some of adult institutions of whether the device actually can improve outcomes in the patients. But there's quite a few literature that has come out recently that is delineating its ability to actually support decreased incidence of renal failure in these patients, hepatic failure, and maintain a stable circulation. When it comes to pediatrics experience with this, we have published a multi-center experience with the device in the United States, and we have found a fairly low adverse event profile with the device, as well as we have published TCH experience early on with an N of 10 patients, showing the fairly favorable performance of the device, as well as a low adverse event profile of the device in our pediatric population. Another indication for the use of the device, and this is quite frequently explored on adult sites, and on adult side, and I think we're finding a lot more experience with this now in pediatrics as well, is the use of Impella in the setting of a VA ECMO support, primarily for decompression of the left ventricle in the setting of peripheral VA ECMO support. Chang et al. Studied the device, the 2.5 device, in the setting of a VA ECMO and showed a favorable hemodynamic profiles with reduction of wedge pressures, CVP, and left ventricular end-diastolic diameter. And then Pappalardo et al. Have studied the device, compared the population with a use of Impella and ECMO versus just ECMO alone, and his population showed lower mortality and more likelihood of recovery of their ventricular function. So a lot more literature is coming up on this, and I think we should stay tuned for certainly our adults colleagues being ahead of us in regards to experience with these devices. So I would like to just take a little bit of time to describe the anatomy of the device. to make sure that sort of you have a clear understanding of how it functions. The device, as I've mentioned, is actually implanted into the left ventricle with the typical appearance of the pigtail sitting right into the ventricle. And the purpose of pigtail is to actually stabilize the device within the ventricle and prevent any type of a suction events against the wall of the ventricular cavity. Then you have the inlet of the device through which the blood enters from the left ventricle. It goes through the inside of the catheter and is directly ejected into the ascending aorta. The device has a motor that's housed right above the outlet of the device. So the device, actually, the motor creates sort of a suction type of a phenomenon that draws blood out of the left ventricle and ejects that blood around the motor. It's important to recognize that the motor is actually has to be protected, and it's protected by something that's called a purge solution that's very specific for this device. The device is typically implanted through a femoral approach in a cath lab through use of fluoroscopy. The device is advanced through the abdominal aorta into the descending aorta, through transverse aorta, down descending in through a specific wire that is placed into the left ventricle, and then the device is sort of secured inside the left ventricle across the aortic valve. Typically, all of our cases have been done in the cath lab, as I think that the use of fluoroscopy is essential in achieving optimal placement as well as positioning of the device to make sure the function of it is optimal. One of my colleagues, Dr. Qureshi, as well as Brian Murray, Vivian Dimas, are experts in the placement of this device in the cath lab, and they've actually looked into a specifically pediatric population implanted with this device, and they have delineated sort of the baseline size of the patient. This was one of our first questions of sort of how small can we go with this device, and they have shown the optimal placement of the device is in the ventricles that have long axis diameter of anywhere around 7.5 centimeters and above, the patients of more than 23 kilos with a body surface area that's more than 0.89 meters square. So that sort of allows us to find that patient population that's fairly safe. However, other institutions in the country have pushed this the boundary a bit, and this has been done primarily by modification of these devices a bit in the cath lab. So what some of our colleagues have done in order to fit the device in smaller ventricles is performed sort of a bending of the pigtail catheter, which enables you to fit more of the device into the left ventricle and shorten the distance from the aortic valve down to the tip of the device, and thus being able to support a bit smaller population. So I think that currently the limit remains the size of the actual femoral artery that can be used to place the sheath and deploy the device through, rather than the actual size of the left ventricle. In some patients, especially those supported with an ECMO support, it's very important to appreciate that there is a potential for arterial compromise. Certainly when the Impella is implanted right next to one of the ECMO cannulas. So some of our colleagues throughout the country, and we at Texas Children's as well, have used a jump graft off of the ECMO circuit to enable distal perfusion of the femoral artery and maintain extremity perfusion and not compromise perfusion of the extremity. This has been described quite extensively in the ECMO literature from smaller patients that are cannulated femorally and enabling them to actually perfuse their extremities using these types of jump graft sheaths that can be used to perfuse distal artery. I think it's important to consider a few sort of things when preparing for implantation and deployment of the device. Number one, we should ensure that there is no LV thrombus on echo. If the patient has an LV thrombus, it's one of the contraindications to use of the device. I highly recommend use of Swan-Ganz catheter when deploying the device. I think the Swan-Ganz is quite essential. Number one is to see the benefit of the device, the reduction in the wedge pressures, as well as very close monitoring for performance of the device and maintaining low pulmonary capillary wedge pressures. So we have deployed Swan-Ganz catheters with every patient that's been supported here at Texas Children's on Impella with maybe exception of one or two. We need to very closely monitor perfusion of the lower extremity, especially if the patient is on ECMO. And if there is a compromise, we should consider those bypass or jump cannula perfusions. And if there is not option for these, then definitely the device should not be considered for use in those patients. It's important to obtain a post-implant TE or transthoracic echo to confirm the placement of the device. And if the system is alarming in the cath lab, we should ensure that the device position is confirmed with a fluoroscopy as well as echo before the patient transitions to the ICU. Otherwise, I can guarantee that you will have a trip back to the cath lab. We should consider titrating P level to the lowest level that's needed, and I'll explain in a second what that means, as we want to reduce wedge pressures and also minimize hemolysis. So just running the device at the highest level doesn't necessarily mean that it will provide you with the best decompression. You might be able to achieve that with the lowest, actually certainly lowest support levels. And then obviously, because of the higher risk of hemolysis with this device, we monitor urine appearance very closely, and any acute, for any type of an acute hemolysis related to the placement of the device. The proper positioning of the device is essential. If the device is not in the right place, it will create suction events, it will create increased hemolysis, and it will be very prone to actually dislocation or malposition and causing more problems rather than benefit with our patients. So typically recommended position of the device, I'm showing you a little bit of an animated echoes here with a transesophageal echo picture here, but more commonly you will be utilizing a transthoracic echo. Typically it's done through 3 measurements and taking an average, with a recommended position of the 2.5 and CP devices to be around 3.5 centimeters below aortic valve, and for the 5.0 and the 5.5 devices to be around 5 centimeters below aortic valve. We want to make sure that the catheter and the pigtail of the catheter is not impinging on the mitral valve, or is not tangled in the mitral valve, because that can actually lead to incompetence of the mitral valve and loss of cardiac output and decompensation in the patient. I've delineated a bit sort of what the true sort of echo picture looks like on this device. Typically, you will see this shadow sort of coming off of the what we call is the cage of the device, which is the metallic part of the catheter, and that gives you this bit of a shadow coming off. So that's where the inlet of the device start, and that's where the measurements should be performed into the aortic valve. So the echo should be performed at the end of the case, as well as right away on the arrival to the ICU, to ensure that it's still in the right position. The device is operated through a use of an automated Impella controller, which is basically the entire brain of the device. It performs up titration of speed and down titration of speed. It actually performs measurements of flow through the device, which is a calculated flow of the device. It enables us to monitor the current of the motor that the motor requires in order to achieve certain RPMs. It allows us to monitor the trends in that current to ensure that that we can actually detect an early formation of a thrombus and impedance in the performance of the device. Most importantly, the device requires what's called a purge solution, and the whole purpose of the purge solution is to maintain a lubrication of the motor at the end of the device, as well as sort of protection of the motor from any blood going into it. So the purge solution is set right at the automated Impella controller. It regulates how much fluid is going into the patient through the purge side arm of the catheter. This is provided at an increased pressure, so the device generates certain pressure to inject that purge solution into the motor. And typically the purge solution is just composed of a form of a dextrose without any saline in it. So it would be typically a D5W solution at baseline. And the device actually modulates or regulates the amount of flow of purge. So that's something that providers need to keep an eye on. and consider for the total amount of fluid that the patient is receiving. Obviously, the device requires also, the 2.5 NCP devices required a saline bag for pressure monitoring, for direct pressure monitoring in the aorta. And so it's set up in a similar way that our arterial line is set up as well. I think one of the most attractive features about this device is a placement screen. So the automated Impella controller displays a screen that allows us to sort of extract various information from it. Most importantly, in the left lower corner, you can see is the flow of the device that the device currently provides. The flow of the device is controlled through various P levels, and the P levels represent rotations per minute. So the higher the P level, the higher rotations per minute, the higher expected output from the device. The P level starts at 0 and goes all the way up to 8. And some of the devices will contain what's called a boost mode or a P9 level, which enables the device to sort of perform at its maximal setting. However, that should be primarily used in the setting of a cath lab and in a very temporizing mode, mainly because the device is performing at its maximal capability and has a high risk of sort of earlier failure or maybe generation of hemolysis with it. Another important aspect of the screen are a flow of the purge system. So it actually tells you how many cc's per hour are going into the patient for fluid calculations. And then the other parameters that are essential is actually placement signal. So that placement signals enables you to measure directly pressure within the aorta. So second sort of source of your arterial blood pressure. It also monitors the current of the motor, so the amount of energy that's used to drive the rotations per minute of the device. And typically, you should see a pulsatile waveform on both of these screens. The reason I mentioned that this is a really attractive feature of the device is because if there is any change in these parameters, you can actually detect when the device is not in the right position. So for example, if the device migrates into the left ventricle, as you can see on the figure in the right upper corner, you will see on the arterial pressure tracing that is indicative of a right ventricular, of the left ventricular pressures with a normal systolic pressures but low diastolic pressures. At the same time, we'll see a change in the motor current, which will become non-pulsatile. If the device migrates outside of the left ventricle and into the aorta, we will see a waveform that indicates the pressure of the aorta, and we will see also loss of motor current. So knowing sort of these changes in the performance of the motor current and the placement signal, we can actually deduct whether there is any malposition of the device and be able to intervene rapidly. The device, the 5.5 Impella, uses a bit different sort of monitoring system because it primarily utilizes an optical sensor that allows for both monitoring of the aortic pressures and calculated monitoring of the left ventricular and diastolic pressures. So you can see on the screen here, the Impella actually provides you with a red, which is your aortic pressure, and a gray waveform, which is indicative of the left ventricular and diastolic pressure. We should note that these pressures are calculated pressures. They're not directly measured, such as those that are in the 2.5 device that have direct channel that measures. This is through a calculations and deduction of a pressure difference as well as a difference in the motor current that enables the engineers to actually provide an algorithm and deduct the pressure in the aorta and the left ventricle. So similar rest of the screen to the other devices with a flow always in the left lower corner, purge fluid being in the middle here and actually providing a pressure for the purge. So that should be monitored very closely as well to observe for any type of presence of clots within the device that might be obstructing flow of that fluid into the motor. It also, the 5.5 device provides cardiac output if calibrated accurately with a Swan-Ganz catheter. And then you have your typical selection from the monitor. You can change your P levels and then obviously perform different procedures. Um, Something specific to the 5.5 device is the optical sensor. Lack of the picto on the device, which enables it to be in a bigger size and a bit longer, providing higher output for the device. And it can be only implanted through a surgical graft. This is in the right lower corner screen that shows you sort of representation of the trends in left ventricular and diastolic pressures. So you can actually see and monitor a patient's improvement once you diurese, once the ventricle starts recovering, you can see potentially a trend. And that pressure should be used more as a trend rather than an actual true number. So in regards to patient management of a patient that's already been implanted with the Impella device, we want to monitor for position, look at the control waveforms. We want to monitor LVN loading, so utilize that Swan-Ganz catheter to monitor pulmonary capillary wedge pressure. We want to observe very closely for the extremity perfusion. Typically, we use NIRS and Dopplers and have pulse ox on those extremities. And then obviously observe for hemolysis, any evidence through monitoring of urine with a Foley or monitoring LDH and plasma-free hemoglobin. The device requires its own anticoagulation. Some of the anticoagulation is provided through a purge fluid through utilization of a heparin. Typically, it started at 25 units per ml, and obviously the purge regulates the amount of heparin that goes into the patient. Typically, it's a very small fluctuation in the delivery of heparin, but requires fairly close monitoring. The literature sort of describes anticoagulation goals. Here at TCH, we use 0.15 to 0.3. The company actually recommends ACT monitoring, and that's mainly because the device has been initially studied for FDA approval in a cath lab setting, and that's where ACT is utilized. So they recommend an ACTs from 160 to 180. In the setting of an ECMO and Impella, we obviously want to shoot for an ECMO anticoagulation goals, so utilizing the purge heparin, but also needing most of the time to add a systemic heparin drip to achieve the anticoagulation goals for ECMO. Similar might need to happen in the setting of just Impella support. If there is not enough anticoagulation on board, we might need to utilize a systemic heparin drip. We want to check the position with echo and X-ray upon arrival to the ICU. It's important because the device can migrate, especially when we go up on the P levels, and that can move the device out of more deeper into the ventricle. We should monitor placement signals, observe purge pressure, sort of trends, and recognize any obstruction. We also recommend using a knee immobilizer to prevent any sort of rapid or extreme extremity flexion episodes in these patients, which can cause arterial injury or tear. We have not that happen here at Texas Children's. We very early deploy our physical therapy team to help with sort of management of that knee immobilizer. We have to be careful because we have seen some nerve compression from the immobilizer, so frequent repositioning checks are important to prevent foot drop. If CPR is necessary, typically we should reduce P level to P2 and then provide IVC chest compressions as needed. And then I just wanted to highlight a couple relative contraindications based on our experience and some of the recommendations from the manufacturers. Main recommendation against use of the device would be any lack of ability to access the femoral or axial artery, inability to use anticoagulation, systolic LV long axis that is less than 7 centimeters, although we have implanted in a patient that was 6.9, but I would say 7 is kind of a lower limit of possibility. The company has a recommendation of not utilizing the device if the aortic annulus is less than 1.5 centimeters, or if the patient has severe aortic insufficiency or artificial aortic valve. We have used it in patients with an annulus of less than 1.5 centimeters, but certainly would not use it in the setting of severe aortic insufficiency, as that would create circular shunt type of and insufficient support. And obviously, as I've mentioned in the previous slides, no intracardiac thrombus is a direct contraindication to use of the device due to high risk of thrombus mobilization and stroke with that. I wanted to share with you guys, this is sort of a patient that's supported on both Impella right-sided, left-sided. So the room tends to be quite busy when both devices are deployed, but we have used it in a biventricular support setting. And so the experience has been growing, and hopefully we'll be able to share some more of it with you guys. But I would like to share a little bit of TCH experience that we have over the past 6 years, and sort of highlight some of the populations that we have learned from. I think our institutional experience highlights the use of the device in pediatric cardiogenic shock, primarily in the settings of temporary support, so acute deployment for shock, and then resolution of it and the removal of the device. We have used the device in the setting of a bridge to durable VAT or a bridge to a transplant. And then obviously we've also used the device in the setting of an ECMO support for direct unloading of the left heart or decompression of the left heart. To date, we have experience of 43 devices. We have used 7 2.5 devices, 24 Impella CPs, and a total of 10 combination of a 5.0 and 5.5 devices. And we have had experience with 2 Impella RP devices. Our experience is in a total of 34 patients. And with 39 left-sided Impella devices. I included this table here to just delineate a bit of sort of patient size information. So our median weight for these patients is around 61 kilos, with a range of 22 to 123 kilograms. We live in Texas, so patients come in big sizes here. We've used it in median of 16 years of age patients, but anywhere from 6 to 42 years of age. And the primary sort of indications include a majority of our patients had myocarditis, rejection after a heart transplant, and then some combination of arrhythmia-induced heart failure, cardiomyopathy, and congenital heart disease. Overall survival out of hospital for this patient population has been at 78%, and 1 year survival from explant has been at 72%. The device characteristics, the predominant device here used at Texas Children's is our CP device used in 58% of patients. And then second after were 5.0 and 5.5 devices in 25% of our patients. The average duration of support when all devices are sort of combined is a median of 5 days, but range anywhere from 5 to 45 days. The primary site of implantation has been the femoral site, and we used 8 devices in axillary position and 1 in subclavian. The reasons for explant included in majority a recovery of ventricular function. We had some patients that required upsize and due to malfunction of the device, and also upsize from a CP to 5.5 device for more of a durable support. And then we actually supported some patients as a durable VATS to a transplantation. When we look at the sort of burden or length of ICU stays and the length of support of these devices, we can see that the 5.0, 5.5, and 5.0 devices are more of our chronic durable support devices with a median length of use in 12 days, ranging from anywhere from 4 to 45 days. Our CP device remains as our sort of temporary support with an average length of support, median length of support being around 5 days and ranging anywhere from 1 to 18 days of support. And then 2.5 is a primarily device used for ECMO decompression, left ventricular decompression, with an average use of 5 days, ranging from 3 to 8 days. I've also sort of helped you understand what our lengths of stay are for both ICU and hospital length of stay for these patients. I wanted to highlight the temporary support group, which is specifically a group that's encompasses majority of the patients with rejecting after heart transplant and patients that have myocarditis, as well as some population of patients that had arrhythmia-induced heart failure. We had quite good outcome with these patients, with 88% achieving recovery and 88% of patients, sorry, that's a bit more than 88%, achieving survival to discharge with this device with this population. Primarily used device in this population is our Impella CP device. We actually looked at a couple of our patients initially. I believe this was a 10-patient experience. We looked at the hemodynamic response to the device and have found a favorable hemodynamic improvements with decreased capillary wedge pressures, decreased lactate, CVP, vasoactive scores, as well as a decrease in creatinine levels at 5 days after implantation. So fairly robust improvement in hemodynamic profile, as well as reduction in medication use and improvement in renal function. Impella with ECMO support is is another sort of indication for use, and we've had a good experience with this population. Primarily, it's been used in the setting of myocarditis, as you can imagine. That population quite quickly goes on ECMO, and then in the setting of severely depressed function might require decompression of the left heart. So we've used that in 6 out of 12 the devices that we use in this population. Had a recovery in 58% of our patients and survival to hospital discharge with 67% of patients. The device distribution is mainly Impella CP. It's at 67% of patients, and Impella 2.5 is used in 33% of patients in this setting. There is a little bit of a sort of a mix of cases where in some cases the Impella was initially deployed for management of shock, and then ECMO was introduced after Impella in 2 cases for basically it was determined to be insufficient support with Impella. And then 2 cases we had implantation of both devices at the same time. This is where we were still learning in our early sort of phases, where we sort of were still not sure of the ability of the device to support. And then most of our experience from then on has been primarily use of ECMO, and then deployment of the device to decompress the left heart. We have also I've also highlighted the population that we use the device as a bridge to a decision-making or a durable VAD or transplant. That is primarily a device with a population with a graft failure, and now we're starting to see a bit more of its use in the congenital heart adult population. These are the patients who are fairly deconditioned, and there's always sort of a question of whether they're optimal transplant candidates. And thus, we have sort of utilized this device to achieve their end organ sort of recovery, to achieve their rehabilitation, and determine whether they can actually be an optimal transplant candidate. 67% of patients have transitioned to a durable VAD, and we had 33% of patients that transition off of that device straight to the heart transplant. Primary device used is a 5.0, but now with the emergence of the new device that's 5.5 liters, we have started to implanting 5.5 devices in this population. I sort of wanted to delineate with this table a bit that bridge to a durable VAD or transplant population. As you can see, we initially started with a graft failure or a transplant-associated coronary artery disease population, and now are starting to sort of explore a adult congenital population and supporting those patients to a, like as I have mentioned, either a decision for a durable VAD or in one case where we're able to actually recover the patient's function and remove them off of the device with recovery of their ventricular function. And I think last, I would like to highlight sort of some of the device-related complications and the patient complications, as I think it's essential for you guys to understand that this device carries with it with itself a certain risk as well. With a total of 41 devices, we had 13 devices that had specific events. And I have to highlight that majority of these events sort of were happening in our earlier experience. Majority of them were suction events, and they sort of remain here and there intermittently, but that's 27% of these events were suction, 27% were related to a malposition. We had in the beginning of our experience quite a lot of perch failure, but we have learned of our anticoagulation. That has gotten better. We had, I believe, two devices that had a motor failure, and that required sort of replacement of the device. Sorry, one device, and the one device had a thrombus in it, was replaced, and patient was escalated to a VAD. Patient-specific complication, the one thing I wanted to highlight here is that we have a 0% of stroke in this patient population. So we have not had any patients have stroke on the Impella support. We did have patients who sustained stroke prior to implantation, or certainly, after durable VADs, but specifically related to the Impella, we are happy to report that we have not had a patient who developed a stroke on the Impella device. But other significant sort of patient complications include oozing at the site, which we consider a minor bleeding, some degree of hemolysis in 18% of patients. We sort of labeled two forms of arrhythmia, such as lethal, which are the arrhythmias that would otherwise result, without Impella, would result in significant hemodynamic instability. And non-lethal arrhythmias are quite common, and those are the PVCs, the random sort of small brief run of a VTAC that might be triggered either by the device touching the sick myocardium or inflamed myocardium. These are not uncommon, but typically do not result in significant hemodynamic compromise. The other two things I wanted to highlight is the extremity weakness, and this is mainly just to highlight the population, those patients that have developed foot drop. So we have aggressively now deployed our physical therapy to monitor for the placement of that knee immobilizer, as we thought it was actually compressing some of the nerves when applied to the extremity and resulting in the weakness of the extremity. So please keep an eye on that if you guys deploy the knee immobilizer in your populations. So where does this device fit into our armamentarium of mechanical circulatory support? I don't think it does not aim to replace any device out there. It's just a complement to our bigger patient population, something that's available and that can be considered. It may expand the role of mechanical assist to patients not currently candidates for other temporary support. So we have previously thought that a lot of our patients with a TCAT or patients with graft rejections were sort of not amenable to a good ECMO support through a transcatheter sternotomy or a VAT placement, certainly in those patients. And we have found a good place for this device in this patient population. And then it may provide a support less invasively to patients that are already candidates for support with other devices, so something to consider. And then last, I wanted to highlight a couple key lessons that we have learned. I think it's important to highlight that team approach is crucial. So having involvement of a CAF team, cardiology, heart failure, and our surgeons at the bedside when making decisions to deploy these devices are essential. This enables you to always have avenues of outlet if things fail, or if things are working well, then the group takes the credit for it, and it's a collaborative effort to get these patients through this. We have to understand that expeditious support decision is important. Once the patient is in multiple organ failure, then you should just go with ECMO. This device will not create sort of superior recovery of end organ dysfunction. So if the patient is already in prolonged state of shock, our experience shows that that the recovery of the organs will might not be as sort of optimal as it would be on ECMO, although we are still learning, and we'll be happy to share that experience as we get more patients. If LV thrombus is present, the decision is easy. Otherwise, it avoids you long debates. If there is a thrombus in the left ventricle, don't put the device in. You will create potential for a stroke. Monitor accurately and aggressively. So Swan guns is essential to be able to design the specific power level of support, the flows, and monitor acutely for the compression of the left heart, whether it's on ECMO or whether it's with the device alone. Proper device is crucial, so don't leave cath lab without proper position of the device. Anticoagulation with purge first is the first therapy, and then including a systemic that is important. Don't leave these patients just with purge therapy if they're suboptimal. You have to have an optimal anticoagulation to extend, especially for those patients that you will be using it as more of a bridge to decision where the device might be used for a prolonged period of time. Higher P level doesn't equal better patients. So just remember that this is where the Swan guns comes helpful. You might be able to achieve full support on a P5 level and not necessarily all the way at P8 level, which might generate more hemolysis or suction events, etc. So very important to titrate to an optimal decompression. And then keep an eye on an extremity and involve physical therapy early. I think these are all of the things I wanted to highlight. Once again, I wanted to thank you all for inviting me and being able to share my experience, and I'm happy to take any questions.